Indian Society of Renal and Transplantation Pathology. She has also won the first prize in Urinary Microscopy Symposium organized by the Department of Nephrology, Gandhi Medical College.
Thank you, ma'am. So we'll straight away go with the case. So we had a 68-year-old male patient, a hypertensive, came with a creatinine of 2.28 milligram per deciliter. Urine routine had 3+ proteins and no significant cells on microscopy. So we received a core needle biopsy of a renal cortex, which had 12 glomeruli and 1 small artery. Among the 12 glomeruli, about 6 were globally sclerosed, which you can see in this picture. These are the different stained sections, serial sections of He, PAS, silver, and MT. On high power view, the viable glomeruli showed mesangial widening, and this mesangial widening was PAS positive, which was more of pink, and it was slightly non-argyrophilic, meaning less of black on silver stain, and MT showed blue in these nodular lesions. And there was no significant increase in cellularity or crescents of fibrin thrombi, as you can see. There was patchy IFTA of about 20 to 25%. So at this point, as we have in the morning gone through all the nodular lesions, what are the differential diagnoses based on the LM findings? So the most common is diabetic. Then comes the monoclonal immunoglobulin deposition disease, fibronectin, glomerulopathy, fibrillary or immunotactoid, amyloid, and collagenofibrotic. All these can have nodular glomerular lesions. But the PAS positive ones are these 4: diabetic, LCDD, fibronectin, and fibrillary or immunotactoid GN. On PASD, that is silver stain, diabetic is mostly argyrophilic, that is black, and rest all are usually non-argyrophilic. On MT stain, diabetic will be more blue, so is LCDD. Fibronectin will be mostly fusionophilic, and fibrillary will be blue. Amyloid will be less of blue, pale in color, and collagenofibrotic, as the name suggests, it's collagen and it will be more blue. So if we are suspecting amyloid, we'll go through with the Congo red stain to confirm. So meanwhile, we went through the labs and his hemoglobin was low, WBC platelets were normal, serum glucose was normal, albumin globulin ratio was nearly normal, and serum calcium was a little on a lower side. Coming to the immunofluorescence, all the immunoglobulins and the complements were all negative, but this is the light chain. Kappa was brilliantly lit with linear smooth deposits along the basement membranes of glomeruli, tubules, and vessels, while lambda was stark negative. So with this picture of nodular glomerulopathy and linear smooth basement membrane kappa staining in the glomeruli, tubules, and vessels, and negative lambda staining on IF is suggestive of light chain deposition disease, and the chronicity was indicated, and it was advised to do serum and urine protein electrophoresis, free light chain assay, immunofixation studies, and bone marrow evaluation. So they did the serum protein electrophoresis, which showed no M spike. Then kappa and lambda free light chain assay was skewed more towards kappa with the ratio more than 100, which is significant. There were no lytic bone lesions or lymph nodes identified. And bone marrow aspiration was done, which showed 8 to 10% plasma cells. Normally the bone marrow should have less than 5%. And this is not very significant, but there is increase. This included even the mature and the immature forms. And bone marrow biopsy had focal interstitial clusters of plasma cells, all indicating or suggestive of a plasma cell dyscrasias. So these are monoclonal immunoglobulins or light chains that are nephrotoxic, and these can cause different kind of lesions in the liver biopsy. So they can be non-organized, as in case of our case. So light chain deposition disease, it could be a proliferative GN with monoclonal immunoglobulin deposits, which is known as PGN-MID, or a C3 glomerulopathy. In these two conditions, in ultrastructure, we'll have a powdery deposits along the basement membrane. The organized deposits can be in the form of fibrils, in which case we will have either amyloidosis or a fibrillary GN, and microtubules in case of immunotactoid or cryoglobulinemic GN, and crystals in light chain proximal tubulopathy or a crystal storing histiocytosis. So with that, based on the physiochemical properties of these immunoglobulins, they kind of deposit in a different way. And in case of LCDD, because they are positively charged or are glycosylated, they deposit on the negatively charged basement membranes. So since these are clonal based and they are nephrotoxic, no matter what amount of tumor burden is there, these needs to be targeted. In our patient, he's undergoing a VRD regimen. He has currently completed 2 cycles, and he'll be henceforth monitored for the same. That's about this case. Thank you.
Thank you, Dr. Nayana. That was a methodical presentation. Nodular glomerulopathy is always challenging, but still you have distilled it in a very systematic way. My question is, how often you happen to see light chain deposition disease? Because as a clinician, we feel that it's very rare, but as a pathologist, what is your experience with that?
So not so often. Diabetic is the most common. After that, yes, it is light chain deposition disease. In the matter of 3-4 years, I have seen 3 cases. That has been my experience.
Fine. So whenever you deal about nodular glomerulopathy, as a clinician, I feel that we have a significant learning curve in mastering nodular glomerulopathy. So what is the pathologist's perspective with regard to that? So is it easy to diagnose it or easy to miss it as a pathologist?
It is easy to diagnose because we are doing different kind of stains which helps us pick it. But there has been an instance in which the patient was having a diabetic nephropathy, and upon that he had LCDD. It is difficult in such a scenario because even the diabetic patients can have that deposits, which are definitely not so strong, but yeah, there was an instant like that. And then the clinician said that SPEP was positive. Then we went back to the slides, and yes, that time we could, tell that it was there. Yeah.
Dr. Nayana, final question from my side. In your case, there was kappa restriction.
Yes.
So for the sake of residents, I am saying, so what would have been the differentials if at all we had a lambda restriction?
The same differentials. The kind of deposits, like it is in the glomerulus, tubules, and also vessels. So it can still be LCDD.
Sure, thank you. So Dr. Rama's insights.
Good selection of case, Dr. Nayana. Any more questions from the audience?
Thank you.
Thank you so much. Now over to Dr. Nishika Madireddy. Dr. Nishika's introduction. So it's a privilege to introduce Dr. Nishika. She is a consultant nepropathologist and lab director, Core Diagnostics, Hyderabad. And she had a lot of publications under her credit. So we anticipate a live discussion from you, Dr. Nishika. Over to you.
Good afternoon, everybody. I will be discussing the case of a 53-year-old female who presented with nephrotic syndrome. The patient had no associated comorbidities, and the systemic examination revealed no significant abnormalities. Biochemical evaluation revealed a 24-hour urine protein of 8 grams per day, and serum creatinine was 1.8 milligram per deciliter. CBC at the time of biopsy was within normal limits. ANA and dsDNA were negative, and the complements were within normal range. So a renal biopsy was performed to evaluate the underlying cause of nephrotic syndrome. The light microscopic evaluation revealed diffuse uniform thickening of the basement membranes, and which showed subepithelial spikes and pinholes on the silver stain. So here itself, it was a clear case of membranous nephropathy even without going ahead with the IF. Now moving on to the IF evaluation. So the IgG showed a diffuse peripheral fine granular deposits of C3T, which were quite significant. I would give it a scoring of 3+ to 4+. There were minimal deposits of C3. There were no deposits of IgA, M or C1q. Now the interesting finding in this case was a strong positivity for kappa and a complete absence of lambda. A further subclassification of IgG was done, wherein there was preponderance of IgG4, as in the IgG4 was dominant, along with minimal deposits of IgG3. IgG1 and 2 were completely negative. Immunohistochemistry for PLA2R demonstrated a peripheral fine granular positivity. The brown deposits that you're seeing here is what is considered as positive for PLA2R. These findings substantiated a diagnosis of membranous nephropathy with kappa light chain restriction, and there were no tubulointerstitial changes of chronicity, and there were no proliferative changes in the glomeruli as well. Now, following the diagnosis of membranous nephropathy with light chain restriction, the patient was evaluated for paraproteins. Serum protein and urine electrophoresis revealed no paraproteins. Free light chain assay and ratio were also normal, and PET-CT was also shown normal findings, that is, there was no significant uptake. Now, with these findings in mind, the nephrologist went ahead with rituximab, and following which there was partial resolution of proteinuria. Patient is still on treatment. We yet to see the future following the course of the clinical course. Now, membranous nephropathy is a common cause of nephrotic syndrome. However, light chain restriction is extremely rare. It was first reported by Evan DJ et al. In 2003 during the autopsy of an 81-year-old female who had follicular lymphoma and showed IgG1 and kappa deposits in the kidneys. Subsequently, a handful of case reports and small case series were reported, and in these biopsies, the dominant pattern was that of IgG3 with kappa restriction. Now, the clinical significance is not completely clear, and even the underlying pathogenesis is yet to be understood. However, an association with lymphoproliferative disorders have been identified. In 2017, Larson and Rocha compiled the most extensive case series of membranous nephropathy with light chain restriction, wherein they examined 30 biopsies from 28 cases. An interesting finding here was that over a period of 6 years, only 0.95% of all the cases of membranous nephropathy showed a light chain restriction. The mean age at diagnosis was 62, and there was no particular preponderance to either of the genders. Now, 2 had an underlying autoimmune disease, and 1 was positive for hepatitis and syphilis. 24 of the 30 biopsies showed kappa light chain restriction, while the rest showed lambda light chain restriction. 19 biopsies were available for IgG subclassification, of which 14 showed a single IgG subclass. Now, in this case series, in contrast to the previous case reports, IgG1 was the most commonly seen subclass, followed by IgG3, 2 and 4. 27 cases had a PLA2R IHC done, of which 7 showed positivity. All of these cases showed kappa light chain restriction, and none showed an association with any lymphoproliferative disorder. Now, 6 patients had a diagnosis of CLPD, 1 of whom developed CLL 2 years following the diagnosis of membranous nephropathy with light chain restriction. Now, all 6 patients did not show any paraproteins on serum and urine electrophoresis. PLA2R was negative, and all 6 stained for a single IgG subclass. Based on their findings, these authors proposed an algorithm to evaluate cases of membranous nephropathy with light chain restriction based on PLA2R and IgG subclass staining. Now, whenever there is a PLA2R positivity, regardless of whether there was staining for a single subclass of IgG or more than one subclass, the author said that MGRS is unlikely in these cases. It most probably excludes the possibility. Now, the scenario where there was the most significant association was when there was a PLA2R negativity along with a single IgG subclass. Now, in these cases, they feel that it is imperative to investigate for an underlying lymphoproliferative disorder. Now, to summarize, majority of the cases of membranous nephropathy with light chain restriction lack a recognizable secondary etiology. However, absence of PLA2R positivity, staining for a single IgG subclass, and focal proliferation are worrisome histological features, and a thorough workup to exclude an underlying lymphoproliferative disorder is essential even in the absence of recognizable paraproteins on biochemistry evaluation. Now, this case series has one case which developed CLL 2 years later, so a follow-up is also necessary. Thank you, everybody.